Okay, everybody, we're going to get started. Thanks for your patience. Good evening. My name is Sarah DeFeo, and I'm the Director of Scientific Affairs here at the Ovarian Cancer Research Fund. And I want to thank you all for joining us today as we continue our webinar series for 2015. So tonight we'll be hearing an overview of exciting ovarian cancer research news that was presented at various medical meetings this year. Our entire webinar series has been supported by Genentech, and I want to thank them for their generosity in making this possible. A little bit about OCRF. We're the largest and oldest charity in the U.S. funding ovarian cancer research. Our mission is to fund scientific research that leads to more effective identification, treatment, and ultimately a cure for ovarian cancer. Since we made our first grant in 1998, we've awarded over $65 million in research grants. Now, before I get started, I have just a few housekeeping notes to go through. All listeners will be in a listen-only mode throughout the presentation. We will have some time for questions after the presentation, so if you think of a question as you're listening, you can type it into the Q&A box that you should see at the right-hand side of your screen. Nobody else will be able to see the questions you ask, and you won't be able to see anyone else's questions, but I'll see them, and I'll select some to ask to Dr. Levine at the end of his presentation. There's no need to wait until the talk is over to submit your questions. You can just type them in as you go along, or as we go along and as you think of them. I do ask that you try to keep your questions as general as possible so that the answers will be useful to everybody who's listening. So I'm very pleased to have Dr. Douglas Levine with us tonight as our presenter. Dr. Levine is the head of the Gynecologic Research Laboratory at Memorial Sloan Cancer Center here in New York, where he's also an associate attending surgeon. He's a gynecologic oncologist who specializes in the surgical treatment of women with ovarian or uterine cancers, and in his lab, he focuses his research efforts on the genomics of ovarian and endometrial cancers. He's a very busy researcher. His research has been supported by all the major funding agencies, including National Cancer Institute, Department of Defense, Stand Up to Cancer, and OCRF. And he's authored over 100 peer-reviewed research papers and serves on many editorial and professional boards, including OCRF Scientific Advisory Committee, where he generously gives many, many hours of his time helping us with our work. We're very grateful to him for that. So, Doug, I will turn things over to you, and you can get started.
Thank you, Sarah, and good afternoon and evening to everyone. I just need to figure out how to share this again, Sarah.
Can you see, Doug, there's a quick start tab in your left hand?
Yes, now I got it. Thank you. Hold on 1 second. It will come up in 1 second. Oops. Okay. Is that working?
Yes, Doug, looks great.
Okay, good. All right. Great. So, oops, what did I just do? That wasn't stupid. Okay, you can still see that?
Yes, we can see it. Thanks.
Okay. I will try to get this to work. Good afternoon, good evening again to everybody. Thank you for joining us on the webinar today. Over the next, 30 to 40 minutes, I'll try to give you some updates on the latest research that has been presented at national meetings this year, focusing mostly on ASCO and SGO. SGO is the Society of Gynecologic Oncology, and ASCO is the American Society of Clinical Oncology. I'd like to thank the presenters who shared the slides that I'm going to share with you today. We will discuss some early phase clinical trials, the expansion of the use of Parp inhibitors, and novel discoveries that have been reported, and assuming time permits, we will get to the surgical management of newly diagnosed ovarian cancers and what was presented related to that. Probably every 5 or 10 minutes, Sarah, I'll just ask you that to make sure you can still hear me, because it's a little funny to be talking into a phone for 30 to 40 minutes without anyone talking back to you.
Sure, no problem.
So with that, before I begin, the most important slide is to thank everyone. And I just really want to mention that all the research that I do, but also all the research that I'm going to be talking about, is really a partnership and it's a really huge partnership between everyone across the world, and that really includes scientists and funding agencies, but most importantly, it includes patients who really are our partners in research, donating their time and their body tissues to help us make new discoveries and make cancer care better in the future. And that's really what the top half of this slide is supposed to show. And the bottom half just is to let you know who I am. If you don't know me, I'm here in the middle. Can you see my cursor when I move it, Sarah, on the screen?
Yes, I do. I see it.
Okay. So that's me in the middle. That's my laboratory. On the right side is our entire gynecologic disease management team at Memorial Sloan Kettering. And at the bottom is the current funding sources of our laboratory at present. I've received funding in the past from the Ovarian Cancer Research Fund, which is the only reason why it's not shown there now. And again, I just show this, even though I'm talking about other people's research today, just to indicate that really it's a team effort and we get support from lots of people across the world for all of us in the field to conduct research in ovarian cancer. So a little background, which will become relevant to some of the studies and projects that I'm going to talk about. And a little background is, what do we know about ovarian cancer? And we actually know a lot about ovarian cancer. We need to know a lot more, but we do know a lot about ovarian cancer. In particular, we know that all high-grade serous ovarian cancers, with rare exception, have a mutation called a somatic mutation, which is an acquired mutation in a gene called TP53. We also know that mutations in BRCA1 and 2 are very common. These can be germline mutations, which means they're inherited from a family member, or they could be somatic mutations, which means they're originating spontaneously within the tumor, and they're not the type of mutation that can be passed on from one individual to another. And just a reminder that our professional organization recommends that all newly diagnosed patients with ovarian cancer should have genetic testing, which is a simple blood test for BRCA mutations, because this can identify patients who may be uniquely suited to receive special treatments with things like Parp inhibitors. And equally, if not more importantly, this can help counsel family members who may be at risk of ovarian cancer. And what you see on the right side of the slide on the pie chart here is that about 15% of ovarian cancer is due to inherited mutations. Now, it is technically possible, it is covered by insurance, and it is easy for us to identify every single person who has an inherited BRCA mutation if every single patient would have testing done. This is covered by virtually all insurance companies. I've not heard of anyone being denied coverage, and I've heard of no cases of insurance discrimination. And so if we can identify every single patient with a BRCA mutation, we can prevent these types of cancers from continuing down family lines, and we probably can reduce the incidence of ovarian cancer by 15% alone simply through genetic testing, which is available today. And so a very important take-home message is have genetic testing. For patients who have mutations, make sure all of your first-degree relatives have genetic testing. The rest of the pie chart shows what else we know about drivers in ovarian cancer. We can turn off the BRCA1 gene expression through silencing the gene. There's other ways that cancer integrity and genomic integrity can be affected. So what this part of the pie chart is trying to represent is drivers that can affect something called homologous recombination, which is a way that tumors can repair DNA. And we know of a lot of other genes that can play a role in the repair of DNA errors by a mechanism called homologous recombination. On the right side of the chart are 3 of the major mechanisms that are not related to this form of DNA repair, including a loss of proteins called NF1 and RB1, and amplification of a gene called cyclin E1. This is background information. Moving on, the reason why this is important, again, is in addition to the inherited mutations in BRCA1 and 2, we now know that there's a handful of other genes that are thought to play a role in the repair of DNA through homologous recombination. These genes are listed on Part B from a paper published in 2014. And these genes, again, these mutations in these genes can be found in tumors from patients with ovarian cancer. It does not necessarily mean that these genes cause the ovarian cancer. These genes can be identified in the germline, which means they are hereditary and can be passed on from person to person, but that does not necessarily mean they lead to the cancer. So we first identify these mutations in people who have cancer. Once we find them in people who have cancer, we initially would think, well, that must be a risk factor that has led to the development of the cancer. But in fact, what you have to do is then measure the frequency of these gene mutations in a population of people who do not have cancer. And when you do that, you'll actually find that many of these gene mutations are present in the whole population of people. And you have to figure out which ones increase the risk of ovarian cancer. And so now, in addition to BRCA1 and 2, it seems that RAD51C, RAD51D, and probably BRIP1 are other genes that are increasing the risk of ovarian cancer over the course of someone's lifetime. So those could be useful genes to test for. There are gene panels that are commercially available, but they're very hard to interpret because if you have a mutation in something like BARD1 or CHEK2, it's not entirely clear that that actually increases your risk or your family's risk of ovarian cancer. And at present, we don't have data to support that conclusion. So moving on to treatment, again, just as background, bevacizumab is an antibody against a vascular growth factor, vascular endothelial growth factor. And to date, there's been 4 studies that have shown that when you add bevacizumab in some manner, usually including many months of treatment, that this treatment can delay the time to which the cancer will return by approximately 3 to 4 months. These studies have been tested in the populations of women with platinum-sensitive ovarian cancer and platinum-resistant ovarian cancer, which means the tumors are either sensitive or resistant to treatment with a platinum chemotherapy agent, which is the most common agents used to treat ovarian cancer. And this drug, bevacizumab, whenever it's given, typically will delay the time to recurrence by 3 to 4 months, but it will not generally affect what's called the overall survival of how long someone will live since the diagnosis of ovarian cancer. So with that in mind, a new study presented at the Society of Gynecologic Oncology meeting in March of this year was a cooperative group study called GOG213. And here was another permutation of using bevacizumab in the treatment of ovarian cancer. This was, again, in patients with platinum-sensitive recurrent ovarian cancer. And again, here the bevacizumab delayed the time that the cancer returned by, again, about 3 months, as was seen in all the other studies. But the unique thing in this report is that, in fact, the overall survival, which had not been previously reported to be significant for bevacizumab treatment, was also delayed by approximately 5 months. Now, this didn't quite reach statistical significance, and so technically it's considered statistically negative, but and there were about 400 plus patients, I'm sorry, about almost 700 patients in the study, but you can see that, again, it suggests that bevacizumab does have some effect in this population and may now for the first time result in an improvement in overall survival. That was presented at SGO. Moving on to a trial presented at the ASCO meeting. I'll cover 3 or 4 or 5 trials here. The first trial was studying a drug called AZD1775, which is called a WEE1 kinase inhibitor. And this was given in women with platinum-sensitive ovarian cancer. And I'll explain this more in a minute. You can see the authors listed here who presented the data or who conducted the trial. So this drug, called AZD1775, sensitizes P53 mutant tumors to DNA-damaging agents such as chemotherapy. So I told you that, I told you that P53 is mutated in nearly all cases of ovarian cancer. And to repair the DNA, the mutated tumors modify what's called the cell cycle, which you can see in a picture here on the right side of the slide. And so the cell cycle is important in determining whether cells live or die, and that's regulated by a enzyme called WEE1 kinase, and this drug inhibits the WEE1 kinase, And the idea is that tumors that have p53 mutations will be more sensitive to this type of treatment. This is a critically important drug because p53 is the most commonly mutated gene in all of human cancers. It's critically important to ovarian cancer because p53 is mutated in virtually all of high-grade serous ovarian cancer, the most aggressive type of ovarian cancer. And so if this were to be highly successful, this would be very, very promising for ovarian cancer and other cancer types. And so what was done in this study is that women who had recurrent ovarian cancer that was platinum sensitive were randomized to either receive the study drug, which is an oral drug, with Taxol carbo chemotherapy, or they received a placebo and Taxol and carboplatin chemotherapy. They were monitored according to standard approaches, and on clinical trials, we typically perform CT scans every 6 to 12 weeks. We measure CA-125 levels usually every month or more, and we monitor for adverse events. And this type of approach is what you'll see on all of the trials presented. And the primary objective here was to see if the progression-free survival was improved in the patients who received the study drug. And to be eligible to go on to the study, you had to have a p53 mutation, and in fact, you had to have a special type of p53 mutation that was categorized and believed to result in loss of function of the p53 protein, because not all mutations that we can identify through DNA sequencing, not all those mutations will result in loss of function of the associated protein. And of course, it's the proteins that do all the molecular work inside of a tumor cell. And so these investigators wanted to screen for mutations that were really thought to lose function. Now, that doesn't mean there are other mutations that wouldn't respond. It's just for this trial, they want to select the 50% of mutations that they were very confident resulted in loss of protein function. And so they did that. And the first analysis was to see if the progression was delayed, and this was statistically significant because they're looking for superiority. They set their threshold at what's called a p-value of 0.1, and here you can see this is called a Kaplan-Meier curve, and for those of you not familiar with looking at these types of curves, on the bottom is time, which is how long it took for the cancer to return. And on the y-axis here is the percentage of patients whose cancer returned. And you can see that for the people who took the study drug, on the green line, this is shifted to the right, which means it took longer for the cancer to come back. And here this is a 3-week improvement in their cancer coming back, which is not a lot of time, but these are patients who have received a prior treatment. And they also used a special type of criteria called enhanced RECIST criteria to identify the intervals here. And in fact, on the next slide, what you'll see is that when they use a more traditional criteria called RECIST 1.1, which is the standard that's used in these types of studies, you'll see that the change in progression-free survival is much greater, and now we see the difference is 8 weeks, which is 2 months. And that's pretty significant when that's about a 20% improvement in the time for the cancer to come back, or actually 25%. And this is a hazard ratio, which means the cancer is almost 50% less likely to come back as quickly in the group that received the study drug. And so this was considered a positive trial. It was very exciting because it's a targeted agent, and the results were that that they met their primary endpoint. They will likely go on to do larger studies of this drug, and it also was very well tolerated. So it's important to not only give drugs, but give drugs that are well tolerated, and this certainly seemed to meet that criteria. Next, we'll move on to Parp inhibitors, 2 studies of Parp inhibitors. And just to remind everyone and to explain the basis for people not familiar with Parp inhibitors, Parp inhibitors inhibit one type of way that the cells can repair their DNA called a base excision repair. It has other functions as well, but this is one predominant way that cells repair DNA. Another mechanism called homologous recombination is highly regulated by the Brca proteins. And so by giving a PARP inhibitor, you can knock out one mechanism of DNA repair. And if a tumor has a BRCA mutation, you'll knock out another mechanism of DNA repair, but the tumor has ways to switch back and forth. And so if you give a PARP inhibitor in a patient who has a defect in homologous recombination, the tumor can't survive both of those defects and the cells die. And that's what you see down here on the bottom left. You see when given to BRCA carriers, the tumors generally shrink because these drugs are quite effective. We've known about this for a number of years now. And after learning that these drugs are effective or highly effective in women with BRCA mutations, some studies have also determined that these drugs are also effective in women who do not have BRCA mutations. And so the question is, why is it, and who are the patients who do not have BRCA mutations who may also respond to these types of drugs? That's one question. So this first study was a phase 1 study to figure out what's the proper dose to combine a particular PARP inhibitor called veliparib in combination with standard agents that are given for ovarian cancer, such as carboplatin and paclitaxel, with or without bevacizumab, in newly diagnosed patients. So many trials are first done in patients who have recurrent disease, but we want to make our initial treatments better, and the idea is, can you add a PARP inhibitor to initial treatment to make it better? And so this study, led by Kathy Bell-McGuinn, was presented at ASCO. Veliparib is a potent inhibitor of the PARP enzymes. It's known to have some activity when given alone in women who have BRCA mutations, and it's also shown preclinically to improve the activity of platinum-based chemotherapy agents. So in this study, there were 3 regimens that were all tested, so different dosing regimens that were tested with the veliparib. And what happens in a phase 1 study is that you increase the dose of the experimental agent to figure out what the right dose is, and I'll explain to you how we do that. This is a very unique phase 1 trial because usually phase 1 trials are often done when we're giving a drug to humans for the first time. We don't know what the safe dose is, and we also are not typically giving an effective dose. But in this phase 1 study, we're actually giving carboplatin and paclitaxel or cisplatin. We're actually giving regular drugs at effective dosages. And so everyone's getting regular treatment for ovarian cancer and highly effective treatment for ovarian cancer. But here we're adding an experimental agent to figure out what the right dose is. And so this is a phase 1 trial, but it's appropriate for newly diagnosed patients because they're getting highly effective chemotherapy with an agent that may make the treatments more effective, but may also carry more toxicity. So it's a potential added benefit with some potential added risk. So the way these phase 1 trials run is that, and I'm not sure everyone's familiar with phase 1 trials, so I thought it'd be nice to just show how a phase 1 trial actually works from a design point of view. And so what happens is you start with a relatively low dose of the study drug, and you see how people tolerate it. And we have certain dose-limiting toxicities. So if people have if patients have their blood counts go down and they develop fevers, that's a side effect or a complication or an adverse event from the treatment. If patients have other problems, like they pass out, which is called syncope, or they have very low blood counts, that's not acceptable. And so we slowly increase the dose, and obviously some patients have side effects from chemo even when we give it, at standard dosages, but we slowly increase the dose until these side effects are unacceptable. And basically at a dose of 150, out of 17 patients, 2 patients had unacceptable side effects, and that is thought to be an acceptable amount of side effects, around 10%. When we go higher, now 6 patients out of 16 had unacceptable side effects, and that's thought to be an unacceptable amount. And these acceptable and unacceptable amounts are always predetermined by the study design before the study is started. And so that's an example of how the study dose was determined in regimen 1, and similarly in regimen 2, the same dose was thought to be effective. As they tried to go to the higher dose, There weren't specific side effects, but patients had to delay their treatments because their blood counts were not recovering in time. And so it was determined that 150 milligrams twice a day was the recommended dose to then test to see if the drug was effective when given in combination with other types of chemotherapy agents. Sarah, you can still hear me okay?
Yes, I can.
All right, thank you. So this was a very important study because this particular regimen is now being tested in a very large phase 3 study that has just been approved and has just opened at the first center in the United States. And there's a study run by the NRG Oncology Cooperative Group called GY3005. It's a study that's sponsored by the drug company AbbVie, being run through the cooperative group mechanism, and it's going to be open at 175 institutions across the United States and many other institutions throughout the world. I'm estimating another 100 institutions across the world, but I don't know the exact number. I don't recall the exact number. And so this was a study that had to be done to figure out what was the right dose to now test in a very large trial that should have, I think, 1,100 patients to see if the addition of this Parp inhibitor to initial treatment will actually make the initial treatments for ovarian cancer better. And so it's one of the first trials we've had in a number of years for newly diagnosed patients, and so we're very excited about it. And like I said, we just had the kickoff meeting recently. A lot of science is going to be done on this trial to figure out who are the responders and who are patients who aren't benefiting from the Parp inhibitors. And we're excited this trial is now opening up at many centers across the world. So continuing with the idea that you know, the way tumors repair their DNA is important, we want to figure out which patients besides those who have BRCA mutations may also benefit from Parp inhibitors or similar therapies. So I mentioned there's a mechanism called homologous recombination that is dysfunctional in tumors that have BRCA mutations, but we know that there's other tumors and patients who don't have BRCA mutations who also have the inability to repair DNA through similar mechanisms. And so we can sequence all the coding regions. We can sequence the whole genome, but we also can sequence the coding regions of the genome, and we can classify tumors into different mechanisms of impaired DNA repair because the tumor leaves a signature of these mechanisms that we can detect. And we can figure out what tumors have the signature of homologous recombination deficiency, or HRD, that is similar to the same signature in tumors that have BRCA mutations or loss of function. And so now we're looking for the other group of tumors, or the other group of tumors that will also respond to Parp inhibitors when there's not a BRCA mutation present. And so to do that, this trial called Ariel 2, which was launched by investigators throughout the world. It was led and presented by Ian McNeish from England, actually from Scotland, I believe, and it was presented at ASCO. And this is just a reminder that there's other genes here shown in a complex that are all important for this DNA repair mechanism to work properly. And when it works properly, Parp inhibitors are not particularly effective. But when it doesn't work properly, the addition of a Parp inhibitor will lead to cell death. And so here, they studied a Parp inhibitor called rucaparib, which is another very powerful Parp inhibitor. It was given FDA breakthrough therapy designation in April of this year, which means it's fast-tracked for approval if certain clinical trial metrics are met, and this is one of the studies that will help set the stage for that. This drug is given also twice a day as an oral agent. And in this study, the patients had their tumors measured for what's called genomic scarring or HR footprint or loss of heterozygosity, where certain segments of DNA are deleted because the repair mechanisms do not work properly. And so we can categorize the tumors into those that have BRCA mutations And those that have that genomic scar or that signature that looks like they would have a BRCA mutation, but they actually don't. And then those who just look like regular tumors that are not affected by any deficiencies in DNA repair, which is called biomarker negative. And when you do that, and on the right side of the pie chart here, if you do that in this study, 20% of patients had a mutation, 40% had a signature that looked like a mutation, and 34% did not have that. Again, these patients were platinum sensitive and had received prior treatment and had recurrent disease. And so here you can see, again, the Kaplan-Meier curve. This time it's in months. And you can see three curves that are quite separate. And so the top curve, or the curve that's most to the right in green, is the patients who had the longest time until the tumor returned. And here the median, or the 50 percentile time here, was 9.4 months. And in the BRCA-like group, it was 7.1 months. And in the biomarker negative group was 3.7 months. So it really shows that this BRCA-like group with the genomic scarring did significantly better than those who were biomarker negative. And so there wasn't a placebo control here, so we don't know if the biomarker negative patients still benefited from the treatment, but we do know that the BRCA mutation group and the BRCA-like group benefited much more than the biomarker negative group. And the responses in BRCA mutant tumors was quite striking, and we learned two other things from this trial. We learned that while tumors that have a BRCA mutation responded to treatment, we learned that the type of mutation, which again, as I talked about before, can be germline or inherited, where there's one copy of the mutation in every cell of the body, and then the tumors have two copies of the mutation in their tumors, or two mutant copies. Those types of tumors responded, but also for the first time we now see that tumors that have the acquired mutation, or called somatic, they also responded just as well as those that had the inherited mutation. And so that was very new information. We all sort of believed that these two types of mutations would be somewhat functionally equivalent, but here it's shown for the first time that they both benefit from Parp inhibitors. So we learned a lot. The drug was also very well tolerated as a single agent. It was highly active. It was the first study to really categorize the tumors based on this genomic signature. And this drug is now being tested in an expanded population to figure out exactly how many people will benefit and to further confirm the results that were shown in this first part of the study. So again, very exciting information about Parp inhibitors, and now really expanding the arena of Parp inhibitors beyond those who just have BRCA mutations. Finally, we'll move over to immunotherapy, which is also a very hot area now in cancer care in general. And the question really is, how will immunotherapy help in ovarian cancer? So two studies were presented. This is the first one. You can see the authors shown here. Again, an international collaboration, as is done with many of these investigational agents in ovarian cancer, where we need to collaborate across the world to come up with useful findings. And so this is a drug that's really an antibody to something called PD-1. And what PD-1 is it's programmed cell death receptor 1, great name. I don't know who named it, but nice name. And what happens is that there's a ligand or a protein that binds to the receptor PD-1. And when these bind to each other, they actually inhibit the immune reaction. And we know from many, many studies that I'm obviously not showing here that the immune response to cancer is very important. And tumors that mount dramatic immune responses generally control the cancers better than tumors that are in an environment where there's not such a good immune response. So these proteins inhibit the immune response, and so if we can inhibit the inhibitors, we will activate the immune response, and that's what these types of antibodies do. is they bind to the receptor so that the tumor can't bind to the receptor, and the immune response and the immune system can be as active as possible. And so the idea is that these drugs will alter the immune response of the host or of the body to the tumor. This drug has been shown to be very active in many other tumor types. You can see here on this slide, melanoma was the first tumor type to show activity, and has FDA approval for this drug. And many other tumors have been tested, but not ovarian cancer up until now. And so ovarian cancer does express PD-1 and in most tumors, and 36% of the tumors express both PD-1 and have the ligand called PD-L1 on the tumor cells. It's not clear if it's more important for the tumor cells to express these proteins or if it's important for the immune system to express these proteins. And that's a question that's being addressed by investigators in all tumor types now to figure out exactly how to monitor and to predict who's going to respond to these agents. But again, preclinical studies show that when you block these proteins, the tumor response is improved. And so this study took patients who had recurrent ovarian cancer who didn't respond to prior therapies. Most patients had received many, many prior treatments, and they received this antibody to PD-1, and their tumors had to express PD-L1, which is again the ligand that binds to the antibody. And so what happened here is there were a few patients you can see on the right side that had a nice response to the drug, and many patients did not. And overall, 11.5% of tumors had a response to this treatment. So certainly we would not call this a home run. We would say there's some minimal activity. Some might say it's promising enough to do further studies. One thing that is noteworthy in many immunotherapy trials is when patients do respond, they respond for a very long time. And so these patients who responded continue to respond. The trial does continue to be ongoing, so more data will be generated. But these responses can be quite good responses, and that's very promising. A second study looked at an antibody, again, to PD-L1 instead of PD-1. Similar story here. You're trying to, improve the immune system's response to the cancer. This is a different drug called avelumab, if I'm saying that correctly. I'm not so familiar with this drug. But in this study design, the study drug was given to 75 patients with recurrent ovarian cancer. The drug was administered every 2 weeks. And again, here you can see that 10.7% of the patients had a partial response. So it's noteworthy that the response rate of 10 or 11% was very similar between two similar populations and two relatively similar types of approaches to treat the tumor. Here again, you can see what's called a waterfall plot, and you can see these are the responders over here to the treatment. Of note, two of the patients had clear cell ovarian cancer, which is a less common type of ovarian cancer. So both these drugs were very well tolerated. All the patients had many prior treatments to suggest that even though it's 10% in this population, this is a population that's very hard to treat. And so in a less heavily pretreated population, we might expect the treatment to be more successful. This drug is going on to further development. So what we really would like to do is figure out which patients are going, which patients are going to respond to the treatment to identify that 10% of patients. And so here's some data from different diseases. On the left is a slightly different type of immune modulation in melanoma, and here's a similar treatment in non-small cell lung cancer. And what was reported last year and earlier this year is that the tumors that have a lot of mutations in them are the ones that are more likely to respond. And it's thought that if the tumor has a lot of mutations, that it may be able to elicit a more brisk immune response or antibody response to the treatment. And so both of these studies demonstrated which patients are most likely to respond to these types of treatments, albeit not in ovarian cancer. Sarah, can you still hear me okay?
Yes, I can. Sorry, I just have to unmute myself, yes.
No, I got you. Okay, thank you. So where does this take us in ovarian cancer? This is one study reported recently by the group from Australia led by David Botel in Melbourne. They did whole genome sequencing on 92 ovarian cancers that were pre-selected to be somewhat platinum resistant and platinum sensitive, not just sort of the what we call all comers, but they were selected to have certain features of drug-resistant disease. And they also determined which tumors had BRCA mutations, and as expected, around 15 to 20%, or maybe just over 20% of tumors had BRCA mutations. But what you see on the right side of this pretty figure is that those tumors with BRCA1 mutations had a higher number of alterations in the cancer genome. These are called structural variations, but basically they're breaks in the chromosomes. And so the patients with the tumors with BRCA1 mutations had more chromosomal breaks than tumors that did not have BRCA1 mutations. And on the second slide here, those tumors also had a greater number of mutations across the genome and across the exome when they had BRCA1 or BRCA2 mutations, but they didn't have very many tumors with BRCA2 mutations. So we also know that patients that are platinum sensitive often have BRCA1 mutations, and here they show that patients who had more tumors that have more mutations were also platinum sensitive. And so the reason I'm showing these two slides is to make the point that it's possible that the BRCA carrying tumors may actually be the tumors that are more sensitive to the immunotherapy and the other tumors that have HR deficiency. And so again, benefit for the BRCA tumors, they may be responsive to Parp inhibitors, but they could be the tumors that are going to be more sensitive to the immune therapy, and time will tell if that's going to be the case. So in the last couple of minutes, I just want to briefly touch on surgery for ovarian cancer. It's a very important topic. Most patients with ovarian cancer do have surgery at some point during their treatment, and it's one of the few modifiable factors that has routinely been shown to affect outcome. And I'll just take you through a few background slides. I'll remind you before I show these slides that on all the studies I've been showing you, the improvement with new agents has been on the order of 3 to 6 months, mostly for bevacizumab, which is kind of one of our more successful agents, 3 to 4 month improvement, with minimal demonstration of improvement in overall survival. So now you come to surgery, and shown here is when we can remove all the surgery initially at diagnosis, the improvement is on the order of years. So here we're talking from 33 months to more than 100 months. And this is when we can remove all the visible tumor that we can see with the naked eye. When we can remove most of the tumor, any tumor that's larger than 1 centimeter, when that can be removed, the overall survival goes up by 15 months, shown in this series from my institution at Memorial Sloan Kettering. But if you say, well, that's just one institution, so if we look across an international study called GOG 182, here, when you took out all the tumor that was that was greater than 1 centimeter, the overall survival improved by 7 months. And this is with one operation. It could be a big operation. It might take 6 to 10 hours to do, but in one day, you're getting a 7-month improvement, which is, probably more than you get with most of the new agents we've discovered to date. Now, if you can take out all the tumor that you can see with the naked eye, that's even better, and you get an improvement in overall survival on the order of years. Some other studies just show similar data, which I'm not going to talk about in the interest of time. But where this is all going is that one presentation from the SGO, from the MD Anderson group, is trying to figure out how can we have more patients be able to have all their cancer removed. And so what they're doing in a prospective trial as part of what's called their Moonshot program, and again presented at SGO this year, is they're assessing patients with laparoscopy. So they're looking in first with the camera with one procedure. They're having two surgeons review the findings to confirm each other's impression. Then they stop that procedure, and at some later date, they do a second operation on those patients when they think all the tumor can be taken out. If they don't think they can take out all the tumor, then the patients get chemotherapy first and then get surgery after a few cycles of chemotherapy after the tumor has shrunk. And by doing this, what they reported is that their ability to take out all the cancer, and this is all visible disease, has gone from 20% to 84%. And the byproduct of doing laparoscopy first is that 50% of patients are triaged or moved over to getting chemotherapy first. After the chemotherapy, when they go back for the second operation, they've been able to remove all the cancer from the patients who ended up having that operation. It's not clear if anybody was not able to get to the operation, but when they did that, instead of 65% of the time, 100% of the time, they could remove all the cancer. That sounds very good, but it gets to a very controversial area in our surgical management. So two studies have been published looking at this approach of giving the chemotherapy first. This is the first study from the EORTC European group. And here you can see at the bottom, if the patients had surgery first or chemotherapy first, there was really no difference, suggesting they would be equivalent. However, the outcomes for both groups were not particularly good. And the problem that's confusing is that in the neoadjuvant group, they actually removed all the visible cancer 50% of the time instead of 20% of the time. So even with this improved surgical outcome, there was still no benefit, in survival. So that confuses people and adds to the controversy. A second study from the British United Kingdom group was just published earlier this year. They did a similar study, again, showing no difference between primary surgery and chemotherapy. The outcomes were not particularly good, but they were able to increase their resection rate more than double in patients who could have complete resection, all the cancer removed. And so, but that still didn't result in a significant improvement in survival. So it leads us to be confused as to the role of neoadjuvant chemotherapy. Is it really helping, or is it more important to remove all the cancer before you see the chemotherapy? This is something that the MD Anderson study is trying to answer. I think it will take a few years until they have the answers. I can tell you it's very controversial within our professional field, and certainly some patients are going to benefit from chemotherapy first. Most patients will probably benefit from surgery first when it can be successfully completed, whether it's complete disease or even the 1 centimeter cutoff has been shown to improve overall survival. And so with that, I'll just stop and say, time will tell until we have all the answers. The targeted therapies do appear to be very promising. The molecular profiling is very useful to select clinical trial candidates. New discoveries will come from additional genomic science, immunotherapy studies, and modern technology. And the proper surgical approach to newly diagnosed cancers is certainly controversial, but every study does demonstrate that aggressive surgery and successful surgery does benefit our patients. If you want to learn a lot more about the advances in ovarian cancer research, there's a scientific conference sponsored by the AACR in October in Orlando. And I'd like to thank the 85 people who are remaining on the line for coming this afternoon. I hope it's been informative and educational. And if Sarah has any questions, I'll stop now and I'll stop sharing my screen, and I can answer any questions. Thanks.
Thank you so much, Dr. Levine. That was great. We do have some time for some questions, and some questions have come in. So let's see. A few sort of straightforward questions first. What percentage of ovarian cancers are platinum resistant?
So at the time of diagnosis, so the definition of platinum resistance is that once someone stops receiving their initial treatment, so once initial treatment is finished, whatever the combination of surgery and chemotherapy it is, once that's finished, then we see how long is the interval after the last dose of platinum chemotherapy until the cancer recurs. The typical time will be on the order of approximately 3 years, but if the cancer comes back in less than 6 months after stopping platinum chemotherapy, that's considered platinum resistant. And initially, when patients are newly diagnosed and initially treated, that occurs about 25% of the time. That's different than in the recurrence setting. So after patients receive many lines of treatment, most patients and tumors at some point will become resistant to platinum. And again, it's measured by the interval between the last treatment of platinum and the time that it comes back. And so unfortunately, most ovarian cancers that recur will become platinum resistant at some point, but when initially diagnosed, it's about 25%.
Got it. Okay, thank you. We have a question about the different types of BRCA mutations. Can you just do a few definitions on a germline mutation, somatic mutation, what those all mean?
Sure. So again, germline mutations are inherited, which means it's passed on from mother or father to son or daughter. Obviously, fathers and sons do not get ovarian cancer, but they can be at an increased risk for prostate and pancreatic cancer and possibly others. So germline mutations are inherited. We can test them with a simple blood test, many commercial ways to do that, and we recommend that for everybody who has high-grade serous ovarian cancer. Somatic mutations are mutations the tumor develops. The tumors develop many mutations, but when they develop a BRCA mutation, it imparts a special functional defect that we know a lot about. But again, most ovarian tumors have 50 to 100 different mutations. We can identify all of the mutations that an ovarian cancer has. It's just that the ones that we see frequently are P53, BRCA1, BRCA2, and a few others. And those are somatic mutations. They're just in the tumor. They're not in every cell of the body. We cannot test them with a simple blood test. We can test them if we do a tumor biopsy, and we do that sometimes, and sometimes it's not necessary or helpful. A methylation is another way to silence a gene. It's not through a mutation in the DNA, but it's through a blockage of the way that the DNA becomes RNA and then becomes protein. We don't fully understand the significance of that mechanism by which we can silence BRCA1. That doesn't actually happen in BRCA2 in ovarian cancer, although the mutations happen in both genes.
Okay, great, thank you. When you were showing the slides about the surgical outcomes, we have a question. The survival rates for surgery, was that for all ovarian cancer patients, or was that at a certain stage?
Those were advanced stage, so typically stage 3C and 4, because those are the patients who have aggressive surgery. Most of the studies were stage 3C and 4, so advanced ovarian cancer, which unfortunately is the way that most high-grade serous cancers are diagnosed. They're usually diagnosed at an advanced stage. And those are newly diagnosed patients who had surgery, well, in the surgical studies, who had surgery as the primary treatment. And then the later slides were the ones that compared it with chemotherapy.
Okay, got it. Let's see, now we're getting a lot of questions here. The big veliparib trial you described, is that open and accruing patients?
The one I talked about that's going to be opening, GY3005, it is just opened. It's approved on an international level. Each individual center has to actually open it locally, so it's open locally at one center. My center, for example, has not opened it yet because we have to put it through the regulatory committees at my own center, so it'll be open soon. And I don't believe the first patient has yet been enrolled because it's really brand new, and it's just in the process of opening. So the trial's approved. It's open at one site. More sites will be opening now, and then patients will start to be enrolled. It's going to take about 2 years, I think 2 to 3 years, to fully accrue the trial. So lots of people will be going on it, and lots of centers will be opening it, and in a matter of months, it should be open at many places.
Okay, great. You mentioned other trials for newly diagnosed patients and that there aren't many. Are you aware of any other trials for newly diagnosed patients?
Put me on the spot here.
Sorry.
Newly diagnosed. So again, this is a phase 3 trial for newly diagnosed patients, and I don't believe there's other phase 3 trials for newly diagnosed patients, except for either the Aerial 3 study or the SOLO studies. There are some Parp studies. I honestly don't know if those criteria are newly diagnosed or not, but nothing comes to mind, and I don't believe at present, at my center at least, that we have other trials for newly diagnosed patients.
You showed all the bevacizumab trials at the start of your presentation. Are you, these are all similar questions, are you aware of any additional trials with Avastin?
Well, lots of trials have Avastin as part of them because when those trials came out, when those trials had started, we were not sure whether Avastin would become a standard of care. Again, the use of Avastin is somewhat controversial, mostly when to use it. We certainly use it a lot. At my center, for example, we don't use it initially. We use it in the recurrent setting. So the question is, am I aware of other studies? So there are many studies that incorporate Avastin into the study design. I am not aware of other studies that are specifically testing Avastin on its own to see if it works in ovarian cancer because we've kind of shown that it does work in ovarian cancer. Certainly, we just showed recently it's working in cervical cancer, so it's being tested in many other trials. It's incorporated into the design of many other trials. I'm not aware of other studies where that's the main research question.
Okay, got it. Here's an interesting question. Now that it's recommended that all serous ovarian cancer patients get tested for BRCA, do you think that the percentage of overall cases will increase, and by how much?
Yes. So just a clarification, we actually recommend that all patients with ovarian cancer get tested. I believe I did say all high-grade serous cases because we don't want to miss those, but because the diagnosis and the histologic subtyping is not a perfect science, the recommendation is actually that all patients with ovarian cancer have BRCA testing. That's not going to increase, I think the question was, is that going to increase the incidence of ovarian cancer? It's not going to increase the incidence because we're only testing people who have ovarian cancer. It's going to decrease the incidence over time by testing the people who have ovarian cancer, and then those people who have mutations will have recommendations to have their family members tested, and then someone who has a mutation, that's a whole different conversation about prevention, which is not really what we're talking about today. But then someone who's a mutation carrier, it's recommended that the ovaries and fallopian tubes are removed at an appropriate time after childbearing is complete and before ovarian cancer will be expected to develop, which would typically be having the ovaries removed at age 35 to 40.
Okay, just a few more questions. I don't want to keep you on the phone forever. Okay, some clinical questions. When is subsequent debulking an option?
So a little bit of a controversial question. That study I showed, GOG 213, actually also is testing for the first time whether subsequent debulking makes sense. So again, a little bit of a controversial question. What I do and what my group does is we have an algorithm for who is going to benefit, who we think will benefit from what's called secondary cytoreduction. And basically the best candidates are those who've had the disease stay away for a long period of time. And when the disease comes back, it's in one or a few spots that could be completely removed. We're fairly confident that in the recurrent setting, the goal should definitely be complete removal. In the primary setting, we would like to do complete removal, but if we could only remove those tumors that are more than 1 centimeter, that still has a benefit. So it's basically for patients that are platinum sensitive, and typically the tumor should be in remission for at least 1 year or more, and it should be in a place that the surgeon believes they can completely resect.
Got it. We have a few questions, sort of similar type of questions about for folks who have advanced cancer, platinum-resistant, what, if they've gone through multiple rounds of treatment, what do you suggest in terms of timing around trying new treatments and enrolling in a clinical trial? When would you guide someone in that position to enroll in a clinical trial or to explore them?
Clinical trials are definitely the way to get access to the newest drugs. And I think patients should go on clinical trials as soon as possible, particularly if you're looking for, it sounds like some of the questions are looking for new agents. And the reason for that is that if some of the treatments don't work and the cancer, spreads, someone may no longer be eligible or healthy enough to tolerate a new agent. More importantly, some of the clinical trials have criteria that you can only receive a certain number of prior treatments. And so if you try to get too many non-clinical trial treatments, by the time you want to go on a clinical trial again, you might not be eligible. And so, it depends on the clinical trial. Obviously, if you have a treatment that is likely to be effective, you wouldn't want to go on a clinical trial that's completely unproven. But as I showed in that veliparib trial, that was a phase 1 trial, but everybody was getting highly effective treatment anyway. And so that would be a trial that anyone could go on. But some of the trials where the drugs are really new, you wouldn't want to go on that trial if there was another agent that was thought to be highly effective. But if there's not a highly effective agent, you want to try the new agents basically as soon as you can, because you can always receive the standard agents, but you can't always get onto a clinical trial. The trials open and close, and there's the other reasons that I mentioned. And another thing I just have to say is in clinical trials, you're really getting really good care because all of your care is predefined. If there's any side effects, it's predefined what to do with that. And so while most doctors are pretty good and practice medicine the same way, there are some things that are just not, prescribed. And in a clinical trial, all of the therapy is really almost decided by a review committee, and so it's likely that you're getting very high-quality care on a clinical trial.
Great, thank you. Okay, last question. It's kind of a big one, but I think it's a good one. In a 1 to 3 sentence response in a public education setting, how would you answer the question, how is treatment for ovarian cancer better today than it was 10 years ago? Tough one.
In a public education setting, such as this one?
Yes, probably just, for the lay person.
Well, it's very simple. I mean, patients with ovarian cancer today are living longer and better than they were 10 years ago. And that's due to improved surgical technique, medical care, and the administration of chemotherapy and associated drugs.
Great. All right, wonderful. So I think we'll end it there. We've been on an hour. So thank you, Dr. Levine, so much for your presentation. And I want to thank everybody for calling in today. Please take a minute to fill out the survey that will appear on your screen at the end of the webinar. Your feedback is very important to us and helps us come up with ideas for upcoming presentations. And for more information about OCRF, you can always visit our website at www.ocrf.org. Before I forget, I do want to say these slides will be available on the OCRF website starting tomorrow, so you can go back and hear this whole presentation again. Okay, that's it. Thank you, everyone. Have a wonderful evening.